So we'll move on to the next surgery. I think this again is the first surgery of the presbyopic ICL known as the EVO VIVA in India. So we'll have a short video on that and then we will go on to the implantation. This is the first time I'm using the lens. It's very similar to the ICL, but it also has extended depth of focus. How much is the cylinder? How much is it? How much is the cylinder? Focus, in focus. So this is the EVO VIVA lens, and that's how the box looks. This is from Star Surgicals, and this patient, is presbyopic. She is 45 years of age, and then lens port. So this is a -8 with a 12.6 mm diameter lens, and this lens is available only in non-toric right now. This patient has about 1.3 diopters of astigmatism, so I plan to manage that with limbal relaxing incisions and then implant the lens, because right now the presbyopic lens is not available in the toric version. So we'll show you the loading of the lens.
What is the reading at for this patient?
It is an extended depth of focus lens with an add of about 1.5 diopters. It gives you a depth of field of about 1.5 diopters. This along with the patient's accommodation, because these patients have some amount of at least 1 to 1.5 diopters of accommodation, so they are able to, most of them are able to read N6 or N5. So you put in a little, the loading is very similar to the regular ICL. You put in BSS and Visco, and this is the lens which comes in the bottle. I pick it up with the sponge, and this is the loading. You'll have to ensure that the right side leading haptic has the hole and the left side. You can also see one more hole here in the periphery of the haptic. This is a partial hole which the regular ICL does not have. This indicates that this is a VIVA lens, which is a presbyopic lens. And the optic is designed so that the central area has lesser myopic correction, so a little bit of a plus add. So that's how you load the lens. Then you use the pull-through forceps and then hold the lens, grasp it, see that all the 3 holes are in one line. Just pull the cartridge. I'm not pulling the forceps, I'm pulling the cartridge, and then you can also rotate it slightly to see that all 3 holes are aligned. So this is the trick if you want the lens to open up correctly. So that's fine. And then this is the That is the plunger, soft tip plunger, which has already been put in there. And that's loading of the cartridge. I just place it in the BSS container and then we will shift the patient. I like to make a single incision of 2.8 mm. I do a wound assisted insertion. The company recommends a 3.2 mm incision for if you want to insert the cartridge into the wound. Light ಕಾಣಿಸುತ್ತಮ್ಮ ಆರಾಮಾಗಿರಿ ಡಾಕ್ಟರ್ ಗಣೇಶ್ ಇಲ್ಲಿ ಆ 3 ಲೈಟ್ ಇದೆ ನೋಡಿ ಆ 3 ಲೈಟೇ ನೋಡ್ತಾ ಇರೋದು ಕಣ್ಣಲ್ಲಿ ಆಡಿಸ್ಬೇಕು. Just keep looking at the 3 lights. Yeah, that's good. So I'm going to do the LRIs first, and you can see that 60 degrees superior and inferior. I'm using a diamond knife. I set it at 600 microns. So that is the 600 micron mark. So these LRIs will correct about 1.3 diopters of astigmatism. It reduces it. So that's the Callisto overlay. The green marks actually give a guide for the 60-degree LRIs. Okay. Then I'm going to make a 2.8 mm light and orthari kannalladisbedi. So it's a 2.8 mm incision. Then you put in xylocaine, and then I use Helon to fill the antechamber. And this is the lens, light and orthari. It's a wound assisted injection. Inject the lens gently, see that the lens unfolds and the landmarks are correct. On the right side you will see the hole on the leading haptic. Inject the lens completely into the anterior chamber. And then you put in some more viscoelastic. You see this hole? This is something which indicates it's a VIVA. The extra hole which is in the periphery of the optic. This is the Ganesh ICL manipulator which is sandblasted on the underside. It's available from Epsilon. It is a cannula, so I put my Helon syringe on the cannula so I can kind of inject to form the AC. I go in and tuck the haptic under the iris. Saline. So you can see that the trailing haptics are tucked in. I go across. You can see the curvature so it doesn't touch the central optic. And then just push into the sulcus. It is centered well. You can see it's a fairly large optic. And then the advantage of Helon GV is Helon 1% is it comes out as a bolus. So you can see that it just takes about 15 seconds to remove all the viscoelastic.
Do you aspirate through the central hole?
Yes, aspirate through the central hole, so the Helon comes out as a bolus. And it's a single incision, so I have not made any side port. I just see that the IOP is kind of set. I like to keep it slightly on the lower side. And then here we are going to check the vault with the online OCT. So that's the beauty of the RTO. You can just check the vault on table. That's the cornea. We need to focus on the lens there. So that's okay. That's good. So we want to see the vault there. Okay. So you can see the vault now. Can you see the vault? That's pretty much. So the vault is around. You can see it's around 400 microns, which is perfectly acceptable.
Shri, do you always tuck the proximal haptics first?
Yes, because then I can go across easily and tuck the distal haptics. If you're doing it from the side port, then you tuck the distal haptics first and then the proximal. But if you're using my cannula, then it's easier to do it this way. So that was the first ICL EVO VIVA implant in India. Thank you all very much for your attention. ಚೆನ್ನಾಗಿದೆ ಕಣ್ಮುಚ್ಕೊ So if there are any questions, we can take them while the next case is getting ready. So this is an extended depth of field lens, the EVO VIVA, unlike diffractive optics of some other phakic presbyopic lenses. And the initial multicentric trials, European multicentric trials, show that the patient satisfaction is quite good. And you can use it for mainly myopes who are presbyopic.